So, good evening, everyone, sir. Uh, Good evening to all the participants and the learned speaker for today. And respected President, sir, may I request you to give the welcome address for this Environmental and Occupational Health DigiConnect webinar, which is Series 1, Issue 37 during these COVID times. And today we have assembled for deliberating on a new topic that will be advances in wound healing. So Dr. Sunil Choudhary is there with us. So Dr. Gajan Kumar is our president from IUS Delhi branch, that is AUS, Association of Environmental and Occupational Delhi. So, Dr. Gajen Kumar, sir.
Good evening, friends. I welcome you all to this 37th issue of our DigiConnect web series. And today we are a very learned speaker, Dr. Sunil Choudhary, who shall be speaking on a very important topic as far as occupational health is concerned. It is regarding wound advances in the wound healing. So, with these few words, I will not take more time, and I welcome you all to this program. And I hand over to Dr. Sandeep Sharma for further proceedings. Thank you.
Thank you, President, sir. So, Dr. Sunil Choudhary, sir, this is the IAOH Delhi branch platform, and we are all members of Indian Association of Occupational Health, and we are all from Delhi branch of IAOH and from IAOH different branches from across India. Or we have been connected by senior members, and this particular webinar is being live telecasted on the YouTube, and the recording will be available after the session. So we are fortunate enough to have you, sir, regarding this deliberation on advances in wound healing, because wound healing is an important topic for we all industrial physicians, and since diabetes, burns, they are all very common, and we have to deal day in and day out with our employees, their dependents, and their family members with these sort of problems, and we need to understand what are the latest advances which are there in the wound healing, and especially in the context of chronic wound healings like diabetic wounds, their pathology, what are the advanced strategies, then how the biofilm it inhibits the wound healing, then latest techniques like negative pressure wound therapy, what are the indications, contraindications, various type of dressings like alginate dressings and other things. So you will be the best person to guide us regarding all this treatment, because all these treatment options are available, but we need to be aware of all these things, that these things are available, and we should give the best to the patient. And for introduction to all the participants who are there from across India, sir. Dr. Sunil Choudhary is Principal Director and Chief of the Plastic Surgery, and he is Chief of Max Institute of Reconstructive Aesthetic, Cleft and Craniofacial Surgery. So this mnemonium is very important. Good, sir. I like this. This miracles which you have made. Miracles is the Max Institute of Reconstructive Aesthetic and Cleft Craniofacial Surgery. Really, plastic surgery can do miracles to the patients. And Dr. Chaudhary joined Max Healthcare as a senior consultant plastic surgeon in November 2003, and is director, Department of Plastic and Reconstructive Surgery, Max Healthcare and Max Institute of Aesthetic and Reconstructive Surgery at Max Super Specialty Hospital. Before joining Max Healthcare, he was a consultant plastic surgeon in the prestigious National Health Services of UK. He has trained many fellows from across the world, hailing from countries like UK, Hong Kong, Singapore, Greece, Ireland, and Finland. He graduated from Maulana Azad Medical College, New Delhi, and he was awarded gold medal for best medical graduate from Delhi University. After his post graduation in Delhi in surgery, he received higher surgical training in the field of plastic surgery from UK and New Zealand, and he received training in microsurgery at Northwick Park Hospital, London, aesthetic plastic surgery and breast constructive surgery at Oddstock Center for Plastic Surgery, Salisbury, UK, for head and neck and microsurgery at Wellington Plastic Surgery Center, New Zealand. His areas of expertise include aesthetic plastic surgery for breast, head and neck surgery, and microsurgery. He has been awarded with a lot of awards like Max Healthcare Excellence Award, Most Trusted Cosmetic Plastic Surgeon in India, Leading Luminary Award by Wound Care Academy, Best Young Plastic Surgeon in India 2011, Chairman Max Healthcare 2011, Sevaratan. And his special interest, as I already told you, is in aesthetic and reconstructive surgery, craniofacial surgery, microsurgery, and body contouring. So, Dr. Sunil Choudhary, sir, the floor is yours, sir. You can start your presentation, and we all will be fortunate enough to learn from you and the guidance which you can give us regarding the management of especially the chronic wounds which are persistently we have to manage as industrial physician in our hospitals. And you can share your screen and start the presentation.
Thank you very much, Dr. Sandeep Sharma, for that very kind introduction, and Dr. Gajendra Kumar as well for inviting me to talk to all the honorable doctors here who are actually part of the Indian Association of Occupational Health. I think without actually much further ado, I'm going to just start with my talk. We all know that the pandemic is raging at the moment, but we must stop the COVID collateral damage because COVID is still not the most common cause of deaths in India. And because of the focus on the COVID right now, what is happening is that the non-COVID diseases and pathologies are totally being ignored. We must understand that if you look at the list of the common cause of deaths in India, COVID is actually at the 11th in the number. So we still need to make sure that the non-COVID patients are actually given their due because a lot of the morbidity and mortality can be because of that. One of the things that as plastic surgeons and as general physicians and vascular surgeons and doctors who are looking after occupational health in the industry as well is the chronic wounds, especially the diabetic foot wounds, foot ulcers, which can have devastating consequences if not treated well. And it can result in not only loss of, basically working hours, it can result in loss of limb and life. So they say that wound healing is natural, but the art of wound healing is basically a smart art. And I'm going to concentrate today basically on the chronic wounds, especially wounds that would not heal with standard wound care. So my focus of talk is basically going to be on chronic wounds and the management and the recent advances therein as well. So let me actually make the talk a little interesting by actually using an acronym. We're very, fond of using acronyms. As Dr. Sandeep Sharma said, the acronym for our institute was Miracles. Similarly, I thought we can actually design an acronym which is SMART. So we are going to use an acronym which is basically going to be our basis of the talk today. So the first letter in SMART is basically S, and there is an SOS, which basically is coming out from the diabetic foot ulcers, save our souls to save our souls. And I think if you talk about chronic wound management, diabetic foot care is actually the number one thing that we should all be tackling and focusing on. So we must tackle diabetic foot care in mission mode. Why? Because lifetime risk of a diabetic to develop foot ulcer is almost 25%, which essentially means that 1/4 of the people who actually suffer from diabetes will develop some sort of a foot ulcer in their lifetime. And as we all know, India is the diabetic capital of the world. Amputations in diabetics are 15 times more common than normal people if they get an ulcer. And every 30 seconds, a lower limb is lost somewhere in the world as a consequence of diabetes. I think the most important thing to understand about diabetic foot ulcer is the pathology behind it. And I've split it into 4 Bs for understanding as to what the pathology of diabetic foot ulcer can be. I think this is one of the most complex of all the chronic wounds. And if you can understand a diabetic foot ulcer, I think you can tackle any of the ulcers or any of the wounds, chronic wounds in the body. So the 4 Bs of diabetic foot ulcer to understand the pathology is the blood supply. B for blood supply. Essentially, as you all know, there can be a lot of vascular insufficiencies because of major arteriopathy. There can be blockage in the main vessels of the leg. But apart from that, there is a lot of microangiopathy as well, which essentially causes basically a change in the vascular permeability, the way the cells actually react to each other as well. There is a huge amount of bioburden in the diabetic foot when they get infected because of the slough that the bacterial toxins create, and the slough actually causes release of cytotoxins, and there is basically an altered immunity, which we're going to talk about in the biology. As you all know, majority of the diabetic foot start with the neuropathy because the patients can't feel anything. They actually get an injury, but they don't have any pain. And this starts sometimes with a very innocuous insult, like a pedicure, or even a small kind of a thorn prick or something which basically hurts their foot when they're actually walking barefoot. And a very tiny little crack in their foot can lead to sometimes a very dangerous, life-threatening or a limb-threatening gangrene. Why does this happen? The neuropathy actually causes a lot of, not only it causes decreased sensation, it also causes changes in the way the local immunity in the cells behave. There is decreased phagocytosis by the macrophages. As you all know, the macrophages are primary cells responsible for basically tackling the bacterial load in the wound. They eat the bacteria, and if the phagocytosis process is basically hampered, then they cannot do so as well. The chemotaxis is also basically altered because of the various cytokines which are actually secreted in the milieu of this diabetic foot wound or the chronic wound. There is an excess of a lot of the metalloproteinases enzymes. Now, one has to understand that metalloproteinases enzyme are the MMPs are essentially normal enzymes which are secreted in the process of wound healing. But in the chronic wounds, there is an excess of these because of the reaction. The wound actually has an interaction with the bacteria and you get slough. The more slough you have, the more MMPs are secreted. These MMPs are inhibitory to the collagen synthesis, and that's the reason why a lot of these wounds don't heal as well. But the most important is the biofilm, and we're going to talk more in details as we go along as well. So the 4 Bs of diabetic foot ulcer: the pathophysiology, bad blood supply, a lot of bioburden, there is an altered biology, and there is a villain called biofilm. So let's go to the second letter in the SMART, which is basically M. I think there are a few magic mantras when it comes to chronic wound healing. The first magic mantra, according to me, is moisture balance. And I think we need to understand this very well. Now, moist wound healing is not a new concept. Dr. George Winter was a British-born pioneer of moist wound healing. And in 1962, whilst he was working at the Department of Biomechanics and Surgical Materials in London, he basically saw that formation of the scab and the rate of utilization of superficial wounds, and basically saw that the conventional wisdom that wounds, when they're allowed to dry out and form scabs to promote healing, was not actually the best way the wounds could heal. Instead, the wounds healed best when they were kept moist. So this is the first time when the conventional wisdom of actually keeping the wounds open, let them desiccate and actually heal, the concept of the wet to dry dressings basically was turned upside down. And this is exactly from where the whole new concept, the modern concept of moist wound healing came into being. And there were further studies which basically proved that decreased dehydration and cell death because of desiccation will actually impair wound healing, because the natural environment of a cell is moist. The task of wound repair requires activity of host of cells like the neutrophils, the macrophages, the fibroblasts, because all these cells not only tackle the bioburden of the bacteria, but also lead to the building blocks of the wound like the collagen. And if these cells don't have a moist environment, they can't move around. And if they can't move around, they can't function properly as well. So, and you also have the various chemicals which basically signal these cells to do their job. And if there is no moist environment, these chemicals also can't diffuse in the wound and actually do their job as well. So moist wound environment is paramount for a good wound healing. It was also found that basically if you have occlusive dressings, in the initial part of the wound at least, it serves as a stimulus, because wherever there is a decreased oxygen tension in the local wound, we are not talking about the supply, the vascular supply of the wound as such from the main vessels. We are actually talking about the local wound, the peripheral wound. And if you actually cause occlusion and slightly low oxygen tension, the angiogenesis actually always proceeds towards region of low oxygen tension. And that's one of the reasons why the occlusive dressings may act as a stimulus in the process. But it's not all about moisture. It's actually about moisture balance. You can't have it too dry, and you can't have a kind of exudating wound as well. So both the things are harmful to the wound. And the actual mantra, the modern mantra, is moisture balance, which essentially means that if you have too much of exudate coming out of the wound, you need dressings which can absorb the exudate. And if you have a wound which is extremely dry and desiccated, you need dressings which will impart moisture to the wound. So the mantra is not just moisture, it's moisture balance. What is our second magic mantra? The second magic mantra is CARE. CARE is an acronym which I basically suggest for comfort and care, advanced healing, reconstruct early, effective and efficacious. Essentially, this summarizes the philosophy that I have about treating these chronic wounds. You can't have a dressing which is essentially painful. And every dressing which basically adheres to the wound is extremely painful to remove. Every time the patient comes, it's a traumatic experience. I think we must make sure that we are compassionate and empathetic to the patients because these patients require a lot of wound dressing changes. So we must make sure that every dressing change basically gives them comfort and care. So we must have dressings which don't adhere to the wound. Then we know that standard wound healing practices like good cleaning, doing dressings regularly, and looking after the various local and systemic factors like control of diabetes, blood sugar, control of the various other comorbidities can actually lead to good healing in majority of the patients. But then some patients, I would say 90% of the patients would actually heal without any major intervention apart from standard good wound healing practices. But then there will always be some patients who will require advanced healing practices. And that's where this talk is all heading towards. The other important thing to understand is that we must reconstruct early. If you see that the wound is deteriorating, you must actually refer this patient to a specialist, like a vascular surgeon or a plastic surgeon, who are actually well equipped to actually deal with large wounds, because large wounds will not heal by themselves without proper surgical interventions. And early surgical intervention obviously always helps in salvaging the limbs. At the end of the day, all the treatments that we offer have to be effective, which means that they should really work fast. There's no point in actually having a dressing changes for months and months and wounds not healing. We must have some amount of timeline where we are able to heal these wounds effectively and efficaciously. And we must have a cost-effective dressing protocol as well. The third magic mantra, according to me, and this is the most important one to understand, is that convert chronic wound and acute wound to make it heal. Why? Because healing is a matter of time, but it is also sometimes a matter of opportunity. Now look at the normal wound healing. Basically, it goes through four defined phases of healing, which overlap with each other as well: hemostasis, inflammation, proliferation, and remodeling. All of us know these four phases of healing. Hemostasis is the moment you actually get an injury, there is actually the platelets pour in, and basically there's a platelet formation, coagulation cascade sets in, and you basically have stoppage of bleeding. And also the platelets aggregate all the factors there to start the wound healing process. Inflammation essentially is all the inflammatory cells like the fibroblasts, the macrophages, the lymphocytes, all of them coming to that place to release their growth factors and release all the processes to actually start the healing process. And then there is collagen formation, which is a proliferation. And once the collagen is formed, most of the collagen in the initial phase of the wound is type 1 collagen, and then it is remodeled and converted into type 3 collagen. And that's basically the scar remodeling or the scar maturation phase as well. So these are the four phases, overlapping phases where a normal wound healing is concerned. But what exactly happens when there is actually a chronic wound? Essentially, a chronic wound is a wound that is stuck in the phase of inflammation. So that's the reason why it never progresses to proliferation and remodeling. Essentially, the wound basically thinks that it is still in the phase of inflammation. So the way to heal a chronic wound is trick the body into thinking that now it has become an acute wound so that it can progress to the next phase and the next phase of healing. So that is where the trick lies. You need to convert the chronic wounds into basically an acute wound to make it heal. None of the chronic wounds would heal if they're stuck in the inflammatory phase. But what exactly are the main problems with the chronic wounds? Apart from the systemic and the local factors that everybody knows about, obviously, if you get a patient of, say, a diabetic foot ulcer, you would evaluate them for their blood supply, the peripheral vascular disease, because that can be a common cause. So you would actually get an evaluation, maybe a duplex Doppler, to see whether there is actually any atherosclerosis or blockage of the main arterial supply of the leg. You would also see and check for neuropathy, because diabetic neuropathy is one of the main reasons why patients get this problem in the first place. Now, maybe we can't change the fact that neuropathy is something in diabetes which does not respond to any treatment. But at the end of the day, it is possible that if we have a good glycemic control of these patients, the neuropathy may not progress very fast. And also, these patients can be given preventive strategies to make sure that they don't actually get foot ulcer in the first place. So they can be actually advised about how to take care of their feet. They can actually inspect their feet regularly. They can have a handheld mirror, which actually they can use regularly after bath to actually check their feet, the soles, to make sure there are no calluses, no corns, no ulcers. And if there is anything like that, they must actually seek advice from the physician. Also, they should control their blood sugars well. And they should also make sure that they don't walk barefoot, because walking barefoot is one of the main reasons why they get injury in the first place. A good footwear, essentially padded footwear, making sure that all the bony prominences where the pressure points are well protected, again, goes a long way in preventing foot ulcer. And as we all know, prevention is the best strategy as far as diabetic foot care is concerned. But once you get a chronic wound, not only there are problems which are the local and the systemic problems, but there are cellular problems happening in the chronic wounds. And these are the main things that we need to understand if we want to tackle these chronic wounds. The host cells are very senescent. They're very lazy. They don't react because they are in a chronic mode. So once they're in a chronic mode, they're almost like in an Italian siesta. They're just sleeping. They're not actually reacting at all. That's the reason why I said that the main mantra of actually healing the chronic wounds is to convert them into an acute wound. And that's the reason why a debridement of the wound, or cleaning the wound up, is a process which actually converts a chronic wound into an acute wound, because you cause an injury, which is a calculated injury, by cleaning up all the slough, cleaning up all the biofilm, and that essentially starts and kickstarts the whole process of healing again. The other thing we all know is there is increased pro-inflammatory cytokines, which actually can be cytotoxic in large quantities, and there are elevated matrix metalloproteases, especially 2 and 9. Now, there are about 50 MMPs, which are responsible for wound healing and other processes. But especially we see that in these chronic wounds, which are not healing well, and when we say chronic wounds not healing well, we're talking about 4 to 6 weeks duration, because if a wound does not heal in 4 to 6 weeks time with a good standard wound care, which means cleaning the wound regularly, dressing the wound properly, and taking all the precautions to make sure that the injury doesn't happen, controlling the blood sugars, controlling other factors which cause these wound problems, even if doing all this standard wound care does not make the wound heal in 6 to 8 weeks time, it means that these wounds really require special care, because these are basically going to be non-healing chronic wounds. And this is exactly where all these cellular processes may be going on. And the other thing, basically the most common thing that we see, why the wounds don't heal in spite of all this time. Now, there are wounds which we find that we wipe them clean, we debride them, they look nice and red. And 2 days later, when the patient comes back, it's again having a yellow kind of a film on the surface. So these wounds basically, we just unable to understand. I mean, we clean them with povidone iodine, we actually wash them well, we debride them, we wipe them clean, and 2 days later, again the same. This is because of the biofilm, and we'll understand this more as we go along. So the third part of the SMART acronym is advanced thinking, and this is exactly where the modern consensus of time concept, again an acronym. I love acronyms, as you can see here. The time acronym is an excellent framework to understand how to actually think about a non-healing wound, because there are four parameters which are extremely important. The T stands for the tissue. There is non-viable deficient tissue, so you need to do good tissue management, basically debridement, removing the slough, taking off the biofilm, and basically treating the wound with dressings which are less painful, not sticking, not desiccating. The second part of the time is the infection or the inflammation control, because as I said, the chronic wounds are stuck in the inflammatory phase. You need to go beyond that. And that's the reason why infection control is an important part of dealing with all the chronic wounds. So any wound that you get, the first thing you do is basically take a pus culture swab and make sure that you know exactly what bugs you're treating. Because antibiotic therapies have to be directed towards proper identification of the bugs which are there in the wound. So without actually proper identification, if we give antibiotics, it may not have any role, and it may promote antibiotic resistance. A word of caution here: that majority of chronic wounds which don't show any cellulitis or acute and chronic kind of an appearance, they don't need antibiotics because they may not actually having a spread. They may be just localized. So these wounds need more local care than actually a systemic antibiotic. But any wound which is actually showing cellulitis, which means there is a redness which is spreading in the wound, the patient is having signs of inflammation like fever, redness, pain, you may need to start them on a short course of antibiotic to control the acute infection, because a lot of wounds are neither acute nor chronic. They may be acute and chronic, which essentially means that the chronic wounds can keep going through these phases where they keep repeatedly getting infected as well in between. So the infection should be taken care of, and infection is taken care of with correct antibiotics, or what we call appropriate antibiotics, and also good wound management. Again, moisture balance, as we talked about before. And the fourth factor is the edge of the wound. Essentially, you need to understand that if you have a large wound, now, if you have a wound which is about, say, 2 to 4 centimeters in size, there is an excellent chance that with good standard wound healing practices, this wound will heal spontaneously by itself, given a chance. But then if you have a wound which is bigger than that, if it's more than 3-4 centimeters in diameter, we all know that the lateral epithelialization may not be enough for this wound to heal by itself, and it will definitely require some help. And it will definitely require help from a reconstructive surgeon like us, because it may need a skin graft or a flap, or some other procedure as well. So this is how we can think about when we actually manage these wounds. This is basically just kind of a framework that helps us in thinking about these wounds. And the other way to think about the wounds is, basically we have to think, what are the main kind of factors which don't let these wounds heal. So three main villains, as far as we are concerned, when we're dealing with chronic wounds, are exudate, infection, and biofilm. And this is essentially, again, coming back to the same things again and again, because we need to reinforce these things when you're managing the bio. There's no harm in repeating these things, because once they get ingrained in our mind, it becomes an automatic thought process. The moment we see a wound, we know exactly what to do about it. So what exactly is a biofilm? We've been talking about biofilm till now, but let's understand why a biofilm is. A biofilm essentially is basically kind of a membrane which is secreted by the bacteria. And this is essentially a self-protection kind of a shield in the form of extrapolymeric substance that they secrete. All the bugs, all the bacteria get embedded in it, and they actually get attached to each other. If you really want to think of it in a very simple analogy, think about the bacteria basically as a unicellular organism. When we have bacteria which are freely floating in the wounds, like unicellular organism, what we call a planktonic bacteria, it is very easy for a macrophage to come like a shark and just eat it like a small fish. But what happens when all these bacteria decide to actually join each other like a multicellular organism in a slimy layer of biofilm, which is basically like a shield? This biofilm means that all the bugs attached to each other form like a multicellular organism, too big for now the macrophages to gulp it. So it's almost like the small fish becomes a big fish when they all join hands. Not only they become a big fish, too big for the shark to eat now, but at the same time, this shield that they actually create around themselves, the biofilm, basically allows all the nutrition to come in, but does not allow penetration of all the things which are detrimental to the survival of the bugs, the bacteria. The antibiotics, the antiseptics, they just don't penetrate the biofilm. The other property of the biofilm essentially is that it can reform very quickly as well. And that's the reason why we are not able to clear it up very fast, because the more we clean it on one day and the other day patient comes back, again, it's there. So this biofilm essentially has a lot of properties that we should understand. Is biofilm same as the slough Well, we need to understand that slough is basically necrotic and dead tissue in the wound. It is not exactly same as biofilm. There may be some superficial biofilm which is stuck to the slough, but removing the slough does not always remove all the biofilm in the wound. The biofilm is usually transparent, so it is not actually visible to the human eye, and it is usually 50 to 70 microns deeper than the surface of the wound. So it is not actually amenable to simple wiping clean of the wound surface with just a swab or a gauze piece. It's basically much more than that. And that's one of the reasons when you have a wound which does not heal with simple dressing means, you need to do a surgical debridement. You need to basically sharply debride all the tissue on the surface of the wound to make it look clean and healthy, almost like red being wound. But then what happens? The biofilm reforms again. So even in spite of doing all these things as well, the biofilm has a property to actually reform quickly and the antibiotics and antiseptics don't penetrate. And there are two bugs which are essentially very, very commonly involved when it comes to biofilm formation, the Pseudomonas. We all see these green pussy wounds. The moment we see green pus, we all know that Pseudomonas, we don't even need to take a swab out of that. But Pseudomonas and the MRSA, the Staph aureus, methicillin resistant Staph aureus, they're very, they're the main, formation, they're the main formers of biofilms. Um, with that, the anaerobic bacteria also join the party. And once all of these are there, there is actually a kind of a multiflora in the wound, which actually completely destroys the wound in no time. This is where the role of the advanced silver dressings comes extremely helpful, as we will talk about it, about the properties of silver dressings and how they can actually destroy the biofilm. So silver is extremely effective in actually destroying biofilm because it works at the cellular level. It basically destroys the cell wall of the bacteria. And one of the other properties of silver is that it basically, the bugs don't develop resistance to silver ions. They don't really seem to have a mechanism for that because silver is actually causing harmful effect to the DNA, and that's the reason why the replication of the bacteria is affected as well, along with the destruction of the cell membranes. It also inhibits many of these enzymes that these bugs basically release for formation of the biofilm. So silver destroys the free-floating bacteria and also the bacteria released from the biofilm in a major way. And also because these bugs don't develop resistance, it is extremely effective at removing this as well. So majority of the advanced wound dressings that we have, as what we call them active dressings, essentially silver is the key component. Now, if you really want to go in the past, we all know that traditionally, even in our households, our dadis and nanis, they used to basically store water in silver vessels and copper vessels. The reason is because the ionic silver would diffuse into the water and actually kill all the microorganisms and make it basically, it will be purified in no time. And it is well known that if you leave water in a silver, glass or a silver pot for more than 24 hours, it essentially kills majority of the bugs in that water. It may not kill that fast because it is in the form of metallic silver, so it does not the ionic silver does not come out so fast. But then if you had a silver in an ionic form contained within a dressing, it would work extremely fast within a matter of seconds. So the concept is not new. We all know that silver is extremely effective at purifying water. And similarly, silver can be very effective in killing the bacteria as well. So let's take active advanced wound dressing, which basically has a technology where a hydrofiber basically has impregnated silver in it. One of the such dressings that we use very commonly is Aquacel AG. I must say that I have no financial disclosures. It is just that we find that this dressing is extremely, extremely helpful in patients where the wounds would not heal in spite of all our best efforts because of the biofilm. So what exactly this technology is all about? Well, the hydrofiber basically comes from cellulose from plants. And not only it sequesters the fluid, it sequesters the toxins and bacteria in a one-way traffic system, which essentially means that it soaks up everything and locks it in place. And even if you compress this dressing, it does not ooze out in the reverse way. Because one of the most important things, if you think about a lot of the dressings available in the market, you will see a lot of foam dressings, a lot of dressings which claim to actually absorb all the exudate. which is fine. But many of these dressings, if you were to actually put pressure on them, and especially in the foot, it would be the moment patient starts walking, there will be pressure on these dressings. They would actually, just kind of, throw out the liquid back into the wound. Now, this is counterproductive. So you need a dressing where everything goes in, nothing comes out. And this is exactly what this hydrofiber-based technology is all about, where everything gets sequestered and does not ooze out laterally. And not only it basically takes out the extra exudation, but it also filters out all the toxins and the bacteria. It gets locked into it. Now, once the bacteria and toxins are locked, now how do you actually tackle it? Once they are locked, you have the ionic silver, which essentially kills the bugs. But there are other things as well, which basically disrupts the biofilm. Now, the EDTA and the BEC essentially have surfactant action, because of which they loosen the biofilm from the wound. Also, the pH is acidic, and the acidic pH essentially inhibits the biofilm reformation. We all know that, all of you probably have used, for Pseudomonas, we've all used a mild 1% acetic acid or vinegar, and we know that biofilm formation is inhibited by these substances as well. So again, traditional wisdom being converted into a scientific advanced wound dressing. When we use things like acetic acid, the effect is there, but then the effect is not long lasting, because it's basically a short acting thing, because the moment the exudate mixes with the acetic acid, it basically dilutes it and neutralizes it. That's the reason why there is an effect, but to tackle chronic wounds with biofilms, you really need sustained action. You need repeated kind of, insults to the biofilm to actually get rid of it. There is no kind of, it's not that you just need one surgical strike. You need plenty of surgical strikes to actually kill this biofilm. So look at this diabetic foot. Essentially, this foot came to us with this kind of slough, almost 3 months of non-healing. It had a gangrene which was debrided locally, but again it failed to heal. There were actually exposed tendons, but the tendons are still viable, because you can see they're still shiny white. They're not looking dull. That's the reason why we did not discard the tendons here, but the rest of the foot has survived. An initial kind of evaluation of this foot was done. Patient was found to have severe neuropathy. At the same time, we also found that there was some occlusion in the major vessels.
Hear me? Hello. Yeah, sorry. So the patient basically had initial evaluation wherein we actually evaluated the vascularity of the foot, and we found that there was actually blockage in the main posterior tibial vessel, which was then the vascular surgeons did an angioplasty and opened it up. And after that, we took over from the vascular surgeons. Now, this wound basically was dealt with help of the hydrofiber silver dressings, the Equacell HE dressings. And over a period of about 3 to 4 weeks, we were able to convert a wound like this into this. Now, this is not just the dressing. This is actually also a good wound practice. Every time the patient would be called after every second to third day. Initially, for the first week, we were calling this patient almost every day, cleaning the wound up, debriding the wound, and then actually putting these dressings on. So we were taking a window of opportunity. So every time a biofilm is removed, to stop the reformation, the silver dressing goes on, and then the next time when it comes, remove more. And this way, we were decreasing the bioburden of the whole foot, and the wound started to heal. Also, as we discussed, we were converting a chronic wound into an acute wound by causing this calculated injury by actually making the wound bed more vascular by actually causing, removing the slough. So this wound started showing signs of healing, as you can see here. After this, obviously, we knew that this wound is not going to heal by itself, because if you go to the time frame, the last thing was E, the edge, and we can see here that this wound is almost 8 by 10 centimeters in size. And so eventually this was basically skin grafted, and the wound healed with no problems. But remember, advanced thinking and not just advanced technologies will heal the wound. So it's very good to have all these advanced wound healing products, and there are plenty of them. And this is the main problem, that there are too many dressings in the market and too little evidence. We talked about a silver combination, the active dressings, which I believe are the best to tackle the wounds which are not healing because they address the specific problem of exudation and infection and biofilm, which I think are the three main villains. But there are lots of other dressings as well. Now, if you think that the main problem is just a little bit of exudation and nothing more than that, then you can use any dressing. You can use a foam dressing, or you can use pads. The foam dressings allow you to leave the dressing on for a little longer time. So you can actually change the dressing every second or third day, which means there is more comfort and more convenience to the patient because patient does not have to travel every day. And it also does not inundate your OPD with these patients on a daily basis. So it basically is more of a convenience thing to use foams. But apart from that, there's not much advantage of that. There are hydrocolloid dressings, which can be useful in wounds which are basically not very badly infected, but they're slow to heal because these wounds basically give a moisture kind of, to the wounds, which essentially aids in the healing. They don't have too much of active ingredients. Basically, it is gelatin or pectin, which just keeps the moisture in place. And when they are in contact with the wound, they melt and they actually give more kind of a liquid medium for the cells and the various, chemicals to basically move around. Then there are liquidy dressings called hydrogels, and a lot of you must have used hydrogels like HydroHeal AM and MegaHeal, which are essentially water or glycerine-based gels. And they can be active as well. You can have silver impregnated hydrogels, which can be useful as well. We find that they can be useful in some of the very, very dry and desiccated wounds, but overall, we've almost converted to more of hydrofiber and silver-based dressings from hydrogels because we found that these were not extremely effective in controlling the wound because a lot of them would make the wound very, very exudative in the process, and that's not very good. So you need moisture, but you don't need flooding of the whole wound. Alginates by themselves don't really have much healing power. They're mostly, they just absorb the exudate. So you can very well just use a normal kind of a gauze or a normal pad on the wound. You don't really need to use alginates because they don't really carry much medicinal value for the wounds. A lot of us use collagen dressings, and the collagen is derived mainly from the bovine collagen. And collagen is the building blocks of it's basically the protein that it serves as a building block. So essentially, if you really think about it, if the wound does not have any problems with infection and biofilm, the collagen that you spray into the wound can work like a scaffold into which all these cells can actually grow in, populate, and then make a matrix. So collagen can be useful in some of these wounds at a later stage once you've actually cleared up all the infection, cleared up all the slough. And so it's a continuum. You need to understand that one dressing will not serve the wound in all its phases. So you may have a wound which basically comes as an acutely infected wound. You tackle the infection. Once the wound basically clears up of the acute pus and infection and slough by debridement, then you go on to dressings which will actually make sure that the biofilm doesn't form, like the hydrofiber silver dressings. Once you think some amount of granulation has come into it, you know that the biofilm is gone. You can stop the active, expensive dressings, and you can actually go on to simple dressings, which can be as simple as just paraffin gauze. Now, one thing that I must say is that the traditional art of dressing, which essentially meant doing saline dressings where the gauze would be left stuck to the wound, and then once it's dry, we would peel it off. This is something that we did as residents as well, and we used to be kind of very happy that the moment we peeled off the gauze, the patient would basically be in tremendous amount of pain and yell. But when we looked at the wound, we say, "Oh, look, the wound is bleeding now. It's red. It's absolutely red." But then, come the next day, we would see that the wound would again actually have, kind of slough on it. Essentially, what was happening is that when the gauze gets stuck, whatever reepithelialization is happening, when you actually peel off the gauze which is stuck to the wound, you actually peel off the delicate keratinocyte, the epidermal layers which are forming as well. So essentially, you're doing more harm to the wounds by actually letting the gauze get stuck. If you really want to do saline dressings, you don't want to make them dry. So you would have to do twice a day or thrice a day dressings as well. And we all know that if you were to do 2 times or 3 times dressing for the wound, a lot of wounds would actually start healing. That's because you're really giving a huge amount of TLC to the wound. TLC meaning tender, loving care, because you're actually looking after this wound not just once a day, but you're actually looking at them 3 times a day. You're cleaning them and you're actually dressing them. And that act itself can make the wounds heal. But then we all know this is very, very labor intensive. This is something that may not be possible at all. And that's the reason why a lot of these dressings, which basically will not stick to the wound and have absorption power, will actually work much better. And that's the reason why a lot of the modern dressings are basically non-adhesive. They can be peeled off without any pain, and they have a lot of absorptive capacity as well. There is the whole lot of enzymes which are used by people as well. But personally, I think enzymes are extremely slow to act. And the best thing would be to actually surgically debride the wound, to clean off all the slough. Even in the OPD, even the general surgeons or general physicians can basically just have a sterile pair of, sharp scissors and forceps. They can just trim off all the slough, and that would really help a lot, because this will decrease the bioburden of the wound. Because more slough you have, the more the bacteria would actually cause more problems to you, because they will secrete more toxins, resolve more metalloproteinases will come into it as well. So I think it's important that we actually remove the slough from the wound. So what we're talking about now is what we call a step down, step up approach, essentially, which means that whenever a wound comes to you, you don't just jump straight away into expensive advanced wound dressing. You first try the standard combination of standard wound care, which then means clean the wound well, dress it with a non-adherent dressing, use appropriate antibiotics, maybe use local antiseptics like neosporin ointment or a mupirocin ointment if you think that's the kind of bug you have in the wound, and see whether it actually responds. If it doesn't, and if it looks extremely dry, non-healing, in spite of all these things, then you actively debride the wound and basically then go for active dressing like the silver-based dressings. And this is basically what we call a step-down, step-up approach, which essentially means that you first evaluate to make sure that there's no causation factors which can be tackled at a different level before you jump onto the active dressings. And this basically can heal the wounds in majority of cases. And this is something that we must always have in our mind. We must have a patient-centric approach. A lot of people say the advanced wound dressings are extremely expensive. But then if you really think about it, if you were to actually call this patient every day for a dressing change, it would probably cost them more than actually having an advanced wound dressing, which would cost a little more in the short term. But then if you were to really think about the shortening of the time in which these will heal, and also the fact that these patients would have more comfort, their infections will get better faster, they'll not have to come to the hospital every day, then I think it would be very cost effective. So we're now reaching almost the fag end of our acronym SMART, and the next letter is R. Basically, this is exactly where we come into the picture, because although 90% or more of the wounds would actually not require our help, but there will be wounds which require our help. And the important thing is to refer early, because early referral can prevent an amputation of a leg. So what is wound bed preparation? This is the main job that we do as reconstructive surgeons before we actually jump on to the real reconstruction. Essentially, it means a wound which is refusing to heal is to be converted into a wound willing to heal. And how do we do this? So there are lots of things that we can do. One of the strategies that I've been doing very successfully is the strategy of peel, seal, and heal. Look at this wound. Very bad necrotizing infection. This is how the wound came to us. And we took the patient to operations. Needless to say, everything else has been already done. The step-down approach we talked about. We evaluated the vascularity, the diabetes has been controlled, the other risk factors have been taken care of, the cardiovascular things have been looked into. Patient is in the hospital, admitted. Now, basically, we're focusing on wound care. And the first thing that we basically have to do is we have to clean up the wound. This is like a radical cancer surgery. If you leave any dead tissue inside, it is a recipe for disaster. It's a nutritional medium for the bacteria. So we must make sure that we debride the wound ruthlessly. And essentially, this is the reason why you need a reconstructive surgeon to do it, because we are bold enough to do it, because we know we can fix this, we can cover this hole. Because majority of times, the reasons why surgeons and doctors are a little hesitant to debride wounds, and they often just take out the top slough, but they never go to the healthy base, is because they think they cannot cover the wound up afterwards, and they don't want to create a bigger hole. And that's one of the reasons why they're hesitant. But this hesitation often leads up to more problems, because the wound just refuses to heal, it progresses, and often lands up with bad gangrenes. So look at this wound, how it was. It started like this, and at the end of my debridement, within half an hour in the operation theater, this is how it looks. But then we all know that the biofilms and the infections don't go away so fast. And in a wound like this, we don't want to end up spending days and days, because this is crucial. If you have a recurrence of biofilm infection, we may not get another opportunity to save this foot. So what do? We apply what we call negative pressure wound therapy. Essentially, if you really think of it in a very simplistic way, it's essentially a piece of foam which is biocompatible, which has basically pores which basically communicate with each other. And it is connected to a suction device, which is computerized, runs all the time, 24 hours, connected to a canister where all the exudate can go into. And it's essentially, if you really think about it, vacuum assisted closure or negative pressure wound therapy is like a 24-hour dynamic dressing. So we just talked about doing the patient twice a day or thrice a day dressing and actually having a good result. Well, you have something better than that. You have negative pressure wound therapy, which works like a dressing which is being changed every moment, because this wound, basically all the exudate that comes out every second is poured out. It doesn't collect in the wound. So all the bad chemicals, all the bugs, the free floating bacteria are not allowed to basically join hands together to form a biofilm, and they're sucked out all the time. So negative pressure wound therapy is one of the biggest advances in tackling chronic wounds, even the acute wounds. And we have had extremely successful, kind of strategy with negative pressure wound therapy. Wounds which would not heal for years, we've actually made them heal in weeks. And we've had lots of these wounds come in from various countries as well. So this is exactly what happens here. You have a foam which basically reduces the edema. It improves perfusion because the negative pressure has been shown to increase angiogenesis. More granulation comes in. There is deformation of the wound, so it actually shrinks the wound shearly by pressure. And the pressure that we maintain is usually about 125 millimeters of negative mercury pressure. You have to understand that we would not use negative pressure wound therapy on patients who have vascular insufficiency, because if you have vascular insufficiency, this can actually decrease the vascularity of the wound as well. You would not use them on wounds which basically have open vessels, exposed major arteries and major veins, because this can cause erosion of the wounds. You would also not use negative pressure wound therapy on patients who are on multiple, blood thinning agents like clopidogrel. Patients who are on aspirin, and if you have a superficial wound, if you can control the hemostasis at the time of debridement, they're actually okay to have negative pressure wound therapy. But patients on clopidogrel, you have to be very careful. We use them in cardiac patients sometimes as well, but we're extremely careful about that. So this is what happened to that wound that we actually saw in the first instance. We basically peeled the wound, which means we basically debrided. Then we sealed the wound, sealing with the vacuum closure, as you just saw. And now we're healing the wound with reconstruction. And here you can see a meshed skin graft has been put. And this again can be bolstered with a negative pressure. And you can see this wound is healed within 2 weeks' time. A wound which would have resulted in an amputation with the strategy of peel, seal, and heal has been sorted out in flat 2 weeks' time. So that's, I think, something that you should really understand, that early referral can save limbs and lives. And essentially, when we talk about the various reconstructive options, there are lots of different options. And when we talk about the basic simplistic way of looking at reconstructive options, we used to think about a reconstructive ladder. But now we have the thought process of a reconstructive elevator, where we will actually choose whatever is the best strategy for that particular wound. And I'll show you one of the advanced techniques of reconstructing wounds with a tissue engineered dermal matrix, which essentially is basically like an artificial skin. So this is a case of a diabetic foot ulcer with necrotizing infection, lower limb reconstruction, which is done with basically a dermal reconstruction template and a negative pressure wound therapy. You can see here that this is a large wound here, which has actually been looked after with wound bed preparation that we all talked about. We've come to a situation where now the wound is healthy, but the wound size is so large and the tendons are all exposed. We all know that in many of these patients, skin graft would not help, because these tendons are basically totally bare and the grafts will not stick because there's no tenosynovium on them. So this is where basically, first we put a dermal matrix, which is basically a tissue engineered biological membrane, which is made up of collagen and chondroitin sulfate. This is bolstered with the negative pressure wound therapy. You can see how it's actually taking. Initially, it turns orangish, and then it turns like red. And once in 2 weeks' time, it is actually taken well, then we basically peel off the top layer of silicone and we cover it with a very thin skin graft. The advantage of actually covering this wound is that it gives us a full thickness cover on this wound, because often we see that if you just put a skin graft directly on these wounds, even if it takes, it causes a lot of problems in the sense of unstable scars. You get repeated ulcerations because it cannot take a footwear, it cannot take a trauma. But if you actually use these dermal matrices, you can actually get a very full thickness skin because the dermis is actually provided by the dermal matrix and the skin is provided by very thin skin graft. And we find that in the long term, these are extremely, extremely durable. They don't adhere much to the tendons, so they allow for free movement of the tendons inside. And we have used this technology in many of these patients as well. Now, we need to understand these are expensive, but at the same time, when it comes to saving the limbs, I think it is really cost effective. So this basically takes me to the last bit of the SMART. Essentially, this is what this talk is all about. Because unless we tackle the gap in understanding, communication, and knowledge, we can't achieve the kind of results that I'm actually showing you. So we need to understand that good wound care can save souls and souls, which means lives, and limb and life both. Wound care is both a science and an art, and that's the reason why a true understanding of what actually happens in a chronic non-healing wound is essential to how we treat this wound. Also, patient-centric approach is the key. You cannot actually have a cookie cutter approach where you put the same kind of thing for every patient. So that's the reason why a flexibility and better understanding of the wound healing is extremely important to see where you need simple wound care dressings, where you need advanced wound care dressings, where you need a specialist who will actually do a surgery or a surgical process. And innovative technologies are really helping us. And we looked at some of these innovative technologies in my talk, the silver-based wound healing dressings. We saw the negative pressure wound therapy, and also how surgery, reconstructive surgery can help in actually healing these wounds. So very important that all of us should work together, because sometimes everybody works hard but hardly achieves anything. That's the reason why talks like this, where I get to interact with you people who are actually going to be the main people treating these patients, and these patients belong to you. These patients look up to you because you are their doctors. It's extremely important for us to have a communication, because you can plug and play. So wherever you need our help, you can actually come to us. Where you don't need our help, you know exactly what to do as well. But we work like a team. And if you work like a team, then something like this will never happen. So thank you very much. This is basically my team at Max Institute of Reconstructive Aesthetic Cleft and Craniofacial Surgery. Our team is fondly called Team Miracles or Miracles team in the entire Max Healthcare, because we are known for doing lots of complex procedures. And to me, wound healing itself is a true miracle, which is happening in the live body all the time. And if we can make this miracle happen, I think our patients will really thank us for it. Thank you very much. I'm
Thank you, Dr. Sunil Choudhary, sir.
open for discussions.
Yeah, you have given a lot of insight about the latest trends in the wound management. And before I open the floor to the other panelists, may I request them to, whosoever wish to ask a question, they have to unmute their mic and they can ask the question from the learned speaker. And sir, there are three questions in the Q&A box. First, we'll take up these questions. Like there is one question from Dr. Sudharma Dalvi. She says that when the finances are limited, use of glycerin and magnesium sulfate with systemic chimeral port or patient education for small wounds in early stages is effective. Your views, please, sir.
Yeah, I think the glycerin again works to retain the moisture in the wound. That's the reason why the moisture balance we talked about. So obviously, glycerin-based therapies really help in that as well. Chimeral fort again basically helps us in actually altering the chemical milieu of the system. It helps in dissolving a lot of the exudates as well. It makes the exudate thin, and that actually allows us to actually clean up the wounds better. So I think in small wounds, the glycerin-based therapies can be helpful, but the concentration of my talk was actually about the wounds that you think have gone beyond this step, and they're not actually willing to heal with these simple things. But again, glycerin-based therapies are integral part of the advanced wound healing as well. And as I said, even the hydrogels we talked about, they're glycerin-based aqua cells, and that's the reason why they're helpful as well. But once you have a biofilm, I think they would not respond to something like this. So simple wounds, they may respond to this. I take the point. It's a very good suggestion.
So that was from Sudharma Dalvi.
There's another question about neuropathy.
Yeah.
Now, it's a very intelligent question because peripheral neuropathy is something that is a real problem that we face, because in spite of good glycemic control, in spite of good blood sugar control as well, some of these patients' peripheral neuropathy will keep worsening and it doesn't settle down. Some of these patients have been helped by neural decompression. But honestly speaking, there are very few of these patients who really have a documented nerve compression which can actually be helped. There are lots of studies where people have done elective neural decompressions for these patients. But honestly speaking, I think the studies have not really proven a true worth of these conditions. I think the main thing has to be focused on prevention more than anything else, because by the time we actually detect a patient with peripheral neuropathy, they have bad wounds, many of them, and this is an irreversible process. So unfortunately, there are not many interventions that are there for peripheral neuropathy.
So, sir, you have given a lot of insight about the management of the chronic wounds, mainly the diabetic wound, especially the debridement, offloading of the ulcer area, dressings, then growth factors, bioengineered this is skin substitutes, extracellular matrix proteins, and MMP modulators, and this. I just wanted to ask you, sir, if you can throw some light more on the hyperbaric oxygen therapy, sir.
Okay. So the two things that I did not focus a lot on was basically, one is hyperbaric oxygen therapy, and the second was essentially the role of the growth factors, because there are platelet-derived growth factors, there are epidermal growth factors. First, I'll just tell you about the growth factors, because very early in our practice, we started using the platelet-derived growth factors. The problem with the platelet-derived growth factors was that a lot of these wounds were very exudative, and the moment the growth factor was put in, I think some of the toxins which the bacteria secrete, they neutralize these growth factors extremely quickly. And that's one of the reasons why the promise that they held has not come true. And also they're extremely expensive as well. Many of these, like the region D, the epidermal growth factors, again, we thought that they would actually help. But then the problem is multifactorial. It's not just a deficiency of growth factor. It's a lot of inhibitory factors which are there in the wound, which basically have to be taken care of. So I think the growth factor story has not been a very successful story. That's what I can tell you. All the studies have proven that they're probably effective in a very minuscule number of patients, but majority of the patients that we are dealing with in India, because of the tropical climate that we have, is the biofilm. And that's one of the reasons why we are not able to actually use these growth factors very effectively. The hyperbaric oxygen therapy is a useful, has a useful place in management of wounds. We are not extremely sure whether it really helps a lot in the diabetic wounds. If you really need to understand, basically the diabetic wounds, often in spite of having arteriopathy and angiopathy, they don't really have too much of a problem with oxygen supply at the basic level of the wound. They have more problems with the way the cells interact and the cellular permeability. So the role of hyperbaric oxygen therapy in diabetic wounds is relatively limited. We find that hyperbaric oxygen is extremely helpful in patients after radiotherapy, like patients who have radiotherapy wounds. And this is where I think the real role of hyperbaric oxygen therapy is there. Also, patients who have suffered from necrotizing wounds once the whole process has been resolved, because necrotizing infections often cause a lot of occlusion and thrombosis this is where the hyperbaric oxygen therapy may help as well. One, hyperbaric oxygen is not uniformly available. It's actually not very easy to find hyperbaric oxygen chambers in most of the cities. And two, it's expensive. I think a single session of hyperbaric oxygen therapy would cost you something to the tune of 800 to 1,000 rupees, and you need about 20 sessions at the least. And there are side effects of hyperbaric oxygen therapy as well. Patients who have cardiac issues, patients who have ENT problems, if they have a ruptured eardrum, they can actually have loss of hearing because of hyperbaric oxygen therapy, because you need to understand the pressurized chamber is giving a pressure of almost 2 atmospheric, 2 bar pressure, and that can actually destroy your hearing as well. So not all patients are suitable for this. Patients who have cardiac issues as well, they don't tolerate this extremely well. So patients have to be screened. But overall, hyperbaric oxygen may be helpful in some of these patients. We don't use hyperbaric oxygen for diabetic wounds because we find that our strategy of actively tackling them with good wound healing practices, preparing the wound bed, and then doing reconstruction at a fast pace. And this is where the negative pressure wound therapy has basically overtaken all the other modalities. But I think in radiotherapy wounds, hyperbaric oxygen is very helpful.
So, sir, as you have told that this peel, seal, and heal strategy, it can help in saving the limbs and major amputations. So, one of the attendees, he is asking for Dr. D.L. Reddy. He is asking for the cost angle. What is the percentage of cure? Will it be 100% or?
Well, it can never be 100%. I mean, there is no, in medical science, no treatment can be 100%. We can't give a guarantee because there are too many factors which are, I mean, the patient's diabetes may be extremely bad. The patient may have a very bad arteriopathy, which is basically also leading to a very poor wound healing. Patient may come with extreme, necrotizing fasciitis infections where the limb is, the limb is in a state where once you debride, it is not a functional salvage, because you may be able to salvage the foot, but is it a walking foot? That's again important, because if you've destroyed all the muscles in the tendons, the foot, and the nerves are all gone, essentially this foot is of no use because it's a cosmetic, remaining foot. So unfortunately, nobody can give a warranty or a guarantee of 100% cure. But what I can definitely say is that this can save a lot of patients from having an amputation. Having said that, if you were to amputate, I would always amputate early, because if you see that the foot does not have a potential to be having a functional salvage, even though the foot can be saved, if you think that the remaining foot which will come after doing the debridement is going to be a useless foot, we tell the patient, we counsel the patient, and we do a very early amputation. Well, sometimes within the first 2 days, we just tell the patients and we do an initial debridement. And the second time when we take the patient, we don't do a second look, we just go for a below knee amputation. Below knee amputation in these patients can actually make them heal extremely fast. Artificial prostheses can be fitted to them in just 1.5 to 2 months. And we see all these patients walking around, because if these patients are in bed, they will develop DVT, pulmonary embolism, and a lot of these patients would die in the next few months' time, just because by being in bed. So I think we are very aggressive, not only with local wound treatment, but even amputation, we are extremely aggressive as well in case we think that we can't do a functional foot salvage. We have no qualms about actually admitting to the patient that we cannot save your foot. We're going to do an amputation. But I always tell the patient, this is not your face, this is your foot. The foot is basically meant for walking. It's not meant for seeing. So, even if you don't have the foot, it doesn't matter because I will make you walk. I give them that promise. So my promise is not to cure the wound 100%, but my promise to the patient is that I will make you walk.
Functional limb is more important rather than cosmetic. There is one more question, sir. Any latest in the handling of maggots?
So there's not much actually. You have to sit down and pick out all the maggots one by one. You have to debride the wound. And basically, you may have to do this a few times before you can actually take out all the, maggots, eggs, and everything out of the wound as well. So it's a painstaking process. Fortunately, we don't get to see too many maggots these days, but once or twice a year we see them. I'm sure in the periphery you see much more. There was an old practice of using turpentine oil, which used to basically suffocate the maggots and they will come out. We often don't use that. We just open up all the pockets, because one of the things that the maggots do is they dig deep. Now, if you look paradoxically, the maggots are also used for wound healing as well in some of the countries, because maggots actually eat all the dead tissue. They don't eat live tissue. But here what happens is, as more slough is there, because maggots are in cahoots with the bacteria, more slough means the maggots keep digging and they go into the bone, they go into the tunnels. And that's one of the reasons why it's very difficult to get rid of the maggots. So I think many times we have to open these wounds. And if you open all the tunnels, you'll be able to get all the maggots out. But you may have to do this a few times before we get rid of the wound of the maggots.
So a lot of comments and appreciation are there in the chat box, sir. You can go in Q&A box also. Now may I request our panelists, now first we start with our president, Dr. Gajendra Kumar, sir. You have any question?
First of all, I compliment Dr. Sunil Choudhary for such a beautiful presentation. And he made such a difficult subject so simple that probably every one of us now understand in and out of the wound healing. So my compliments, sir. My very small question: the wounds you have shown, is it? What is the percentage of the people in the diabetes you get such type of wounds, and what are the percentage of people those are non-diabetic?
So majority of the wounds which are basically non-diabetic are essentially the arterial ulcers and the venous ulcers. And they are the ones which are usually looked after by the vascular surgeons, because most of them would actually require a vascular intervention and these wounds would heal. Sometimes we have our vascular surgeons who collaborate with us very closely, and they do the vascular procedure, because we also evaluate all the patients for vascular insufficiency. Even the diabetic wounds would have a vascular insufficiency. So we will send the patients first to them, and then we will start with the reconstructive. I would say that about 70 to 80% of our wounds are actually diabetic wounds, and the rest of them are non-diabetic wounds. Some of the wounds would be necrotizing fasciitis. They could be immunocompromised patients with necrotizing fasciitis. We even had dengue patients with very bad necrotizing fasciitis, and these wounds keep on lingering for days and days because the patients are so bad, and they become chronic wounds in the end as well. So it's a mixed practice. We see a lot of acute wounds as well, but we are talking today about chronic wounds. I would say that diabetic wounds form almost 70 to 80% of our practice. And I think they're the ones which basically require a lot of these attention to the wound healing, because other wounds like the arterial and the venous, they require more of procedures to enhance their vascularity or tackle the venous insufficiency. The moment you do that, they actually start healing in majority of cases.
Thank you.
Dr. Shiva Ramakrishnan, sir. Dr. Shiva is a past president he's from Mumbai.
Hi, Dr.
Yes, sir.
Can you hear me?
Yes, we can hear you, Doctor.
Yeah. See, first of all, an excellent talk.
Thank you, sir.
Secondly, we are all, we belong to prevention better than cure.
Absolutely, absolutely. I support that.
And why is it that the diabetics, they don't promote every year lower extremity Doppler?
Yes.
Because that can prevent lot of these wounds.
Yes, I agree. So in our setup, we basically have a very active preventive, wing as well. So they do ankle brachial index on these patients. We also have, devices to detect the neuropathy. You can detect neuropathy with simple filaments, the SM filaments, or you can literally, if you don't have filaments, you can just literally take a toothpick and actually just test these patients, because at the end of the day, it's not important what is the magnitude in terms of real scoring system. All you need to know is whether it's a mild neuropathy, it's a severe neuropathy, because severe neuropathy are the patients where you really need to focus and make sure they don't get into trouble. Mild neuropathy patients would often be quite good with simple foot care, because foot care is extremely important. That's the reason why I said patients should all be taught good foot care. And my job would be done if these patients don't end up with me, because all the patients that end up with me are the ones who are really bad. And maybe at some stage they've slipped. Either they have not come with the wounds early enough to the clinician, or the clinicians themselves have not appreciated the magnanimity of the situation, and they have actually treated them like simple wounds. They never thought that these wounds become, overnight they can become. I've seen patients with simple pedicure, in 2 days' time they have a gangrene of the toe, and we have to amputate the toe. So I think prevention, as you said, is the key to handling all the diabetic, foot disease patients, so that they don't develop an ulcer in the first place. Because if they develop an ulcer, they have a 2 to 3 times or even 4 times more chance of getting an amputation than a normal person. So I think a more concentrated campaign to do this would really be in order. However, I think this is a work that the associations like yourself can easily do. The drug companies are not interested in this purely because they want to promote their products. But as far as we are concerned, our diabetic teams, they actually do a lot of counseling for foot care. Once our patients have been treated, we have to prevent a recurrence of the ulcer as well, because these patients have a very high incidence of recurrence. And this is where every patient who is healed from our department basically gets a complete rundown on how to look after their foot in the long term. And we tell them that if you don't need to see us ever, we'll be very happy.
Thank you.
A lot of awareness need to be required by all our industrial physicians and occupational physicians also regarding the preventive aspect of the diabetic foot, especially tests which you have tests for neuropathy or the Doppler test as Dr. Shiva has advised. So accordingly, from patient to patient basis, we can decide on this. So we are now joined by Dr. Vivek Chand Rao. He is also past president from Hyderabad. Sir. He will. Yeah.
Thank you. Thank you, Dr. Sandeep. Good evening, Dr. Chaudhary. It was a very educative talk. I'm so impressed. I'm educated. So, sir, will you please comment on the raw papaya dressing on non-healing diabetic ulcers? That's number one. What sort of ointment or treatment should be given for the facial injuries, especially in growing children, like lacerated injuries or incisional injuries, etc. To prevent the scar formation, what should be done?
Okay. So the raw papaya dressings essentially are enzymatic dressings because of the papain that is in there. Yes. It can be helpful in debriding the slough. So some of these wounds which prevent early, they just have the infection causing the slough and may not have progressed to the stage of the biofilm and the problems that we talked about in the whole talk. So these patients may be helped with that. However, I think there's not really been a very structured kind of a scientific study into this, but there are papain enzyme kind of preparations that are now available in the market as well, which are much more concentrated than say simple raw papaya, and you may be able to use them. Our own experience with enzymatic dressings has not been very encouraging purely because it takes a lot of time. It doesn't really work very fast, and being surgeons, we are very impatient. So something that we can just literally pick up a scissors and a kind of a forceps and just trim it in just few seconds, the enzymatic dressing may take days to do, and that's one of the reasons why we are not using it in our normal practice. But I think there are papain enzyme dressings which are available, and some people use that in the general kind of practice as well. Coming to the facial injuries, the way we manage facial injuries, because they are acute wounds and face being extremely vascular, heals up very fast. We actually nurse all the facial injuries open, and we actually encourage people, even if we stitch them up or we actually have abrasions, we actually ask them to actually wash the face twice a day, and we basically advise applying an ointment. So you can apply something like a Neosporin ointment, which is easily available, or a mupirocin ointment to prevent any infection. And even if you think that infection is not really a reason to worry about, because if you think it's a very clean injury, a simple Vaseline, petroleum jelly is more than enough for a lot of these patients. If you have a abrasion which is actually not dirty and you clean it up with soap and water, you can just simply apply a layer of petroleum jelly, and just daily application, maybe twice a day, is more than enough, because these wounds would heal up in 5 to 7 days time. This crusting is basically what we need to avoid, because when you have crusting, then often underneath the crusting, basically there is infection which lurks in. The bacteria, they take shelter under the crusting. So if you wash daily and if you actually apply the petroleum jelly, not only it gives a moisture, it retains the moisture within the wound, it forms an occlusive kind of a dressing without actually putting a dressing on, because dressing a facial wound is very difficult anyway. You can't really put a big dressing on the face. So a petroleum jelly based dressing, simple petroleum jelly is also good in most of the cases, or a Neosporin type of ointment, which also has paraffin as a base, is all that you really need in most of these injuries, and they just heal very well with that. You don't need to put occlusive dressings in the facial wounds, because One, it is difficult to retain. Two, it's not required because they're very quick to heal.
Thank you, sir. Thank you.
Thank you, Dr. Rao, sir. So, Dr. Srinivas Shanbhag, sir is our past president from Mumbai, sir. Dr.
Yeah,
Choudhary.
thanks, Sandeep. Thanks, Sandeep. Outstanding presentation, Dr. Sunil Choudhary.
Thank you, sir. Thank you, Dr.
Outstanding. You, as somebody said, you have made it so simple. So it's a complex subject. Well, only, I just wanted to ask you one question, which is, it's about 30 years ago, all these tools were not available.
Absolutely.
And I've seen a surgeon use jaggery dressings.
Yes.
Jaggery dressings, and he used to boil the jaggery and then put some gauze pieces in it, and then you autoclave them and put it on the dressings.
Yes.
And he used to get very great results.
Yes.
Though it took time.
Yes.
Would you like to comment on what is the mode of action of jaggery or sugar or honey on dressing?
So I was in New Zealand for about a year. I did a fellowship there. And as you know, there's a New Zealand honey called Manuka honey, which is basically has medicinal properties.
Yes.
And it seems to have some growth factors in it, which actually helps the wound to heal. And the hyperosmolar nature of the honey basically retains the fluid in it and provides a moisture to the wound as well. And it also sticks to the wound and actually provides like a cover. And because of the hyperosmolar nature, there is actually a problem with the bacteria. The fluid goes out of the bacterial wall, and a lot of these bacteria actually die because of that as well. There is a very good scientific study to show that some of these wounds do extremely well with honey impregnated dressing. One of the things you need to understand is all honey is not good, because the concentration of the honey would actually determine how hyperosmolar it is. A lot of the honey we get in the market is basically all adulterated honey with just sugar syrup, and that would be counterproductive. So if somebody takes honey from the jar that we actually buy in the supermarket and put it on the wound, believe me, the wound will deteriorate because you're actually providing a substrate for the bacteria to thrive on. So I think you need to really, honey dressing is good, but then it has to be done in a proper way. The scientific honey dressings basically are sterilized. They're impregnated into the gauze, and there are only some types of honey which have medicinal powers. Not all honeys have. So Manuka honey comes from the pollen of the Manuka kind of plant. And this seems to have a lot of growth factors in it, which actually help to heal. So I think the concept is good. And we used to use honey dressings in New Zealand, and some of these wounds would do well. But as I said, you don't have a cookie cutter approach. So every wound will not heal. Anecdotally, we always tend to think like that. When we use 2 dressings on a patient and we think it has healed, we say that this is the best thing. This is like how it works with all patients. But unfortunately, we see so many chronic wounds. In spite of all the gadgetry that we have, the technology that we have, we often have to shuffle between one and the other. Sometimes we use one kind of type of thing, it doesn't work, then we go to the standard traditional dressing also sometimes. Even the silver dressings don't work, then we actually call the patient every day and do the tender loving care of the wound, every day scrub it and nicely take the infection out. And sometimes you just do surgery, because, one has to understand you can't keep going on for months dressing a wound, you have to call a shot and say, well, this needs a surgeon, a surgical strike.
Thank you. I agree with you. One size doesn't fit all.
Yes, absolutely, sir.
Yeah. Thanks a ton. Excellent presentation. We are very, very happy to have you on this.
Thank you, sir. Thank you for giving me the opportunity.
Thank you, sir. Dr. Shanbhag, sir. Now, Dr. Tyagaraja, sir.
Dear sir, very good lecture.
Thank you.
Most informative lecture, sir. We are very fortunate to hear your lecture. Sir, I have 2 questions. One is, youngsters today, they start smoking, then come to drugs, alcohol, then they end up in pancreatitis and diabetes. And they go with this peripheral neuritis, and sometimes very small ulcers over the toes, because people advise them to go for walking or play something, and they go for this kind of small ulcers. That is question number 1. Second thing is, I am an orthopedic surgeon. We see a lot of diabetic people come with a charcot joints. You may be knowing that arthropathy. And here, when we take an X-ray, completely this metatarsal and phalanges have been disappeared. We can see only the complete soul has been exposed to the exposed, and even sometimes we see the bones. I mean the remnant bones only, the parts bones we see. And what exactly the mode of treatment here, sir? Some people refuse to go for an amputation because they says that amputation, and especially in youngster ladies who are between 40 to 50, who are having some children, suppose marriage going children and all, they hesitate to take this amputation. And we go to the main hospitals or any hospital, they says until unless you go for an amputation, we cannot do. Dressing is very demand this one. We can't do dressing for a long time, and this won't heal also this charcot joint. These are the this one. How best to be treated these kind of cases, sir, with your experience, kindly?
Thank you, sir. So essentially, Dr. Tyagarajan, the first question that you had was about the smokers. I think I am actually very harsh with the smokers. I show them the mirror. I tell them that smoking means that you have a bad chance of actually healing. And if you don't stop smoking now, you're going to lose your limb. Because smoking definitely is a very high risk factor for, bad wound healing. And there's not much you can do if these patients often, never stop smoking because of their addiction. I think we just need to tell them that if you don't stop smoking, then there's not much I can do because we're not God at the end of the day. So smokers have to be tackled in a very harsh, in a very realistic way, and they have to be shown the mirror. That's how I see it. And obviously, they may have a lot of other problems with the peripheral vascular disease. And this is where sometimes only the vascular surgeon can help if they need to have a procedure for increasing the vascularity. They may need a bypass, they may need an angioplasty. Now the endovascular procedures are helpful as well. We see a lot of endovascular procedure where they can put a stent even in the distal part of the posterior tibial and the dorsalis pedis as well. And they have shown very good results with that. So some of these patients would really help. The second question you had was about Charcot's joint. The Charcot's foot is an extremely difficult one with almost no solution in sight, because these patients look as if all the bones have undergone osteomyelitis, but they don't really have infection in many of these cases as well. The foot actually does not have infection. It is just basically degenerative disease because of the various neuropathy and all the other things which are going on at a cellular level. These patients basically either, if they are not willing for an amputation, then they need to be given special footwear where they can have almost like a non-weight bearing kind of a walking, because we now have braces which are basically adapted to the calf, and they actually there's like an artificial foot which has a distance of almost a couple of centimeters between the foot and the foot itself, the artificial foot. So these patients can actually walk on this artificial prosthesis, which is like a strap-on. It is basically like you have the foot retained, your leg is not amputated, but there is a strap-on prosthesis where the artificial foot is actually below your normal foot. So there is a distance between that. And you have a padded kind of footwear on the other side to balance up the height difference. And these patients are able to walk on that. So we have used this in a lot of the patients where we actually operate on the foot, because sometimes when you do flaps on the foot as well, you don't want these patients to walk for a while. But if the patients are in bed, they will get other problems like DVT, pulmonary embolism, and they may die because of these things. So what we do is, once the initial phase of 1 or 2 weeks is over, then we give them this, walking brace, as we call it, which is a total non-weight bearing walking brace. And this is something that they can actually use. That's one of the solutions. But overall, if you have a bad Charcot's foot, honestly, a below-knee amputation is the best solution for them. And one has to basically, again, kind of keep counseling them and tell them that if you can't walk on this foot, then what good is this foot for you? And I think a majority of people, if they're counseled well, they will eventually come to this conclusion that amputation is their best option. And with the amount of good prosthetics which are there in the market, if you just tell them that people have climbed Mount Everest with bilateral amputations, with fantastic, they've run marathons. I think they have to be shown those stories, and our prosthetists are very good. They actually show them videos of people who are actually had bilateral amputations with us, and they're still able to walk. And I think that instills a lot of confidence. So I think it's all about counseling. Most of these patients would actually come to this conclusion. I don't really have a solution. if you as an orthopedic surgeon don't know what to do with Charcot's foot, honestly, I am at my wit's end to actually do it. But as I said, there are a lot of orthopedic procedures and foot procedures in the bone which can help these patients. So the deviation of the toes, if you have, basically, all these toes which are like hammer toes, if you can correct them, those things can sometimes help. Even fusion of the joints can help sometimes as well. So I would say that some of the orthopedic procedures, if they're done early, when the deformity is just visible and there are no ulcerations, I think they can help. Even if you have a big toe ulceration where the whole thing is collapsed, fusing the joints can actually sometimes help these patients along with the wound management. So I think there's a huge role of our orthopedic colleagues in that. The vascular surgeons, the orthopedic colleagues, plastic surgeons, and the general practitioners, and the diabetologists, and the nutritionists, and the physiotherapists, and the prosthetist. It's a total teamwork, sir.
This will be a teamwork for managing this
Absolutely.
sort of things.
Thank you very much, sir. Thank you.
Thank you,
Thank
Dr. Tyagarajan.
Tyagara, sir. There's one question from Dr. Anand Krishna. He's also a panelist here. That what is the role of this? Should we go for angiography of the foot and hello?
So so what we, in our practice, what we do, we can do two things which are very simple as a screening tool. So you can do an ankle brachial index, which basically, if it is low, then if it's less than 0.9, 0.8, 0.7, then basically you need to really evaluate with maybe angiography. Some of these patients may have a high ankle brachial index as well because of the calcified vessels. So they may have an ankle brachial index which is like 1.2, 1.3, which basically basically goes against the whole thing, because it means that there is very good blood supply, but it isn't the case because there may be calcific arteries which cannot be compressed when you're taking pressure. Then you should do basically a thigh, not an ankle, but a thigh brachial index. So you just need to take blood pressures at this 2 point and divide the two. So the ankle blood pressure and this, and you take a value, and basically that can be a very good screening tool. That's number one. So everybody has a blood pressure cuff. You just need a separate blood pressure, 2 blood pressure cuffs, and you can do it. The other thing we use very routinely is because a lot of these patients, the palpable pulses are not there because of the swelling, edema, wound, everything. So you can use a handheld Doppler. We have that in our practice, so we do use a handheld Doppler to listen to the sound of the pulse. You can quickly do that. But if you don't have access to these, then a duplex Doppler would be a good screening tool to begin with. If a duplex Doppler shows a blockage or shows a lack of the flow, then I think that's the next step, that you actually send it to the vascular surgeon for an angiography. But all patients don't need angiography.
Okay. Our vice presidents are also there. Dr. Rajiv Kumar Jain, sir, Dr. Ashish, Dr. Kamla Fartyal. If you have any questions or any remark, then you can.
Good evening, Dr. Sunil. I'm really happy to see you here. And the topic was so very comprehensive. The presentation, I know how difficult it must be for you to, have the multidisciplinary team to work on a patient, because this is one area where you require so many specialists to work on a single patient, and that too for a very long time. And the results are so gratifying only in the centers where they have a comprehensive multi-specialty team. Because what I've seen is, unless you have a support from a prosthetist and a vascular surgeon and a physician who has an interest in endocrinology, especially diabetology, and also a psychiatrist and a counselor who actually help in managing diabetes and smoking together. De-addiction, in fact, you need a psychiatrist as well as a counselor and a psychologist to actually be able to do successful counseling and de-addiction procedure. What has been your experience in terms of their job continuity? Because that is another important challenge which you must be facing, because these people, their earnings are lost because they lose the job, or they have finished their leave also. The social stigma of having a chronic wound How do you tackle these issues? That would be my question to you.
So one of the participants asked me a question, what was the percentage of cure and can I give a 100% guarantee to these patients? And the answer that I gave was that I tell them that I will make them walk, because unless they're able to walk, there is no chance of them going back to the job that they were doing. And that's the reason why all these strategies that we talked about, basically, not only are we tackling the wound healing, but we are actually tackling them in a time frame, which essentially means that we want to make them heal as fast as possible. The smaller wounds, people can be actually going there to their jobs and getting these dressings in between. But patients who have large wounds, we have a time frame of about a month to 6 weeks in which we want to make sure that they actually heal. Some of the patients who will end up with bigger procedures may take 2 months to heal as well. But uh, the thing is that if you don't make them walk, then they have no chance of going back to their work. But fortunately, I think a lot of the patients that we have treated, the main problem is not that they will go back to work, but the main problem is that they start ignoring their feet after they're healed. So, as one of the panelists said, that prevention is an extremely important strategy. We must educate these people, and I think we are lucky to have a podiatrist with us as well. So we often ask these people to make an appointment every 3 months to 4 months and see a podiatrist to make sure that everything is going well, because we don't want to be lumbered with the very simple things because we are specialists. But at the same time, I think it's not a bad practice for these patients to go to their general physicians or podiatrists if they have an access to every 3 to 6 months and get their feet examined and make sure that everything is good. So prevention is the main strategy, because recurrence of the ulcer and the problems that happen again and again are the basic problem that we face. Obviously, there is a problem of all these services not being available at every center. But now that we are all connected, I mean, the whole point of this talk was, and the last bit of my smart, acronym was tackle the gap. This is the gap that we had, that we were not able to communicate to each other. Somebody sitting in a big kind of a PSU like Indian Oil or other PSUs may not know whom to refer to. But now we have put a face to that person when we are all talking to each other. You'll feel much more comfortable referring to a doctor you know about, you've heard about, you've seen him, you've spoken to, than a doctor you just know by name on a piece of paper. So I think this whole strategy of us coming together, I think this pandemic has been a blessing, because we would have probably never done it such a scale. But now more and more webinars are happening. Sometimes there are many webinars happening, but these webinars really give us an opportunity to interact with colleagues in distant places like this. Somebody sitting in Delhi, somebody in Chennai, somebody in Mumbai, and all of us are talking to each other at the same time without even leaving our premises. I mean, what better thing can we? Some of us are even sipping a cup of coffee and having fun. So I think that tackling the gap is probably the key to make these patients go back to work as soon as possible. A very good physiotherapist and a prosthetist is paramount, because they need good footwear. They need information about how to look after their feet so they don't develop these, ulcers again. And I think we are very fortunate that we've been able to get all these things together in our center because of working very hard at it. But I think you need to refer to a good center. I think the delay in referral is basically what is costing many times these patients. And there is no excuse for not referring, because I think all patients can actually move around. They can go from one center to another. People do that all the time for things like cancer and heart surgeries and all. Why not for wound care? Wound care is equally detrimental to their limb and life. It's not a simple thing. In fact, more limb and lives are lost because of bad wounds and diabetes than anything else.
A related issue, what you feel that engaging with the employer, especially HR department, would be helpful?
I think that's a job that you will be kind of more skilled at doing than me. We have our own problems with our own HR, so I would definitely leave it to your kind self, all of you, to actually communicate, because I think it's important that if you have a patient who's going to develop a disease, that's going to be more expensive than the preventive care. So I think regular camps, and we've been doing diabetic foot care camps on our part as well. We sometimes go to the big factories and big associations, even the RWAs, and we organize a camp where people can get their blood sugar checked. They can have their ankle brachial index in case if we feel there is a risk of developing something. Neuropathy can be checked. The feet can be examined. So I think regular foot care camps can really be an excellent way of actually screening these patients who will not normally come to you. So maybe once or twice in 6 months, you could have some of these camps where you don't really need much gadgetry. You just need a simple filament to check, or even a simple, things like simple cotton wool and simple toothpick to actually check the neural sensation in the foot. And you basically need to feel the pulses. And if you can actually refer these patients wherever you think the foot is actually showing signs of vascular insufficiency or signs of ulceration to a higher center, it will save a lot of these patients from ending up with amputations.
Thank you, Dr. Sunil. Your smart is really smart. And your hospital has a suffix of smart as well. Great to have heard you. Thank you.
Mr. Rajesh. So, if there's any other question before we conclude, Dr. Maruti from Bangalore.
Yes, sir.
He has done his course in trauma.
Yeah. Yes, sir. Yes, sir. So my question, yes, sir.
Maruti Nandan with the Sanjeevani.
Thank you, sir. Thank you, sir. Dr. Sunil, sir, it is an excellent presentation and enlightening us with the smart way, sir. It makes us to understand very simple way. My question is that I'm working as an occupational specialist. So that during our industrial injuries, the terminal phalanx of the hands, we get sometimes maybe a chopped wound or a crushed wound like that. How about this reconstruction and the outcome of these things, sir? And one more question is the recurrence of the keloids over the some bony areas like sternal areas and infected keloids. How we have to handle these things, sir? Two questions, sir. Thank you.
Okay, so the fingertip injuries is what you're talking about. Okay, we get a lot of fingertip injuries. The essential thing in the fingertip injuries is a lot of these injuries, the tip is just hanging, okay? And the nail bed in the terminal phalanx bone is basically fractured. But because the fingertips have excellent vascularity, majority of these tips can be salvaged. And a lot of times people make a mistake of actually thinking that if it is just hanging by a strand, this tip would die. But if you were able to stitch it in place, it would actually survive. The important thing is to reconstruct the nail bed with very fine sutures, because absorbable sutures, because if you don't do that, then you will have a lot of problems with the abnormality of the nails. But if you have a tip where the fingertip is amputated partially, if it is a very minor kind of a tip loss, you can just basically do simple dressings, and often it would heal spontaneously, like a centimeter or a centimeter and a half defect will just heal simply with simple dressings, just paraffin gauze dressings and just cleaning up. If you have bigger than that, then sometimes you may need to have more specialized care in terms of, say, a flap reconstruction. Nowadays, we're lucky that we're using dermal matrices, which are tissue engineered artificial skin, and we're getting excellent results with that. We just even almost 2/3 to half of the pulp, we just put it there, and spontaneously in 2 to 4 weeks time, they heal as if there's no scar at all. I mean, it heals up. Even we have seen the finger prints coming up as well. So we are really amazed with the kind of regeneration which happens. The fingertips actually heal extremely well if they're taken good care of. But if you have a lot of loss of the tissue, then it needs specialized care. You will need to send it to a reconstructive surgeon. That's number one. Number two, keloids are very difficult. There is two strategies. One is the prevention strategy, where use silicone sheets and pressure to actually prevent them. But essentially, keloids happen in some locations, like after a heart surgery or on the shoulder, or sometimes people have very bad keloid tendency. They can get it everywhere as well. But once you have established keloid, the smaller keloids will respond to triamcinolone steroid injections into the keloid. So we normally use triamcinolone 40 milligram per ml, and we inject anything from 0.23 to 1 ml depending on the size of the keloid at multiple locations into the keloid. You should not inject subcutaneously, you should inject into the keloid. The first injection is extremely difficult because it's very hard, and every 3 weeks we repeat it, because the steroid actually basically encourages the collagen degradation by promoting collagenase formation, and that basically melts the collagen, which is the hard collagen inside, and replaces it with the good collagen, the type 3 collagen. And so steroid injection, the triamcinolone injection into the keloid is one of the things, but the technique is very important. We've had patients who've had triamcinolone injected in the subcutaneous tissue under the keloid, and they actually gain weight and their diabetes goes out of sync. So very important, the technique. It has to be intralesional. That's one. If they are very big keloids, then we combine carbon dioxide fractional laser with the steroid injections, and that strategy is extremely useful. If the keloids are even larger than that, then you may have to do surgical excision, cover the wound, and then start preemptive steroid injections and laser therapy as well. But fortunately, although keloids are extremely difficult, in a step-up approach, we can tackle most of them.
Thank you so much, sir. Thank you so much, sir.
So, Dr. Santosh Datar, last question, sir. Dr.
Okay,
Datar.
excellent and informative presentation.
Dr. Datar, Mumbai, he is a senior colleague from IUH here.
I'm so honored. Everybody from all across the
lot of things we learned. Just last question, very related to our specialty. Any new recent this thing on chemical burns, because we see them a lot in the industry.
So, unfortunately, a lot of the chemical burns, the problem is that if you leave the chemical on the surface, it keeps on percolating deep inside. And it basically, some of the chemical burns may have an antidote which you people would be more accustomed to. But essentially, we believe that you need to, when you get acute chemical burn.
Thank you, Dr. Datta. So if there is no any other question from the panelists, or if they want to have any observation, we can conclude the session, sir. Dr. Sunil Choudhary, sir, we are fortunate enough to have you during this session. Lot of insight for almost 2 hours. There was a continuous discussion and deliberation on the wound care because this is a very important and step, and lot of new insights are now there in the wound care management. And thing is, we all industrial physicians, we should be aware, and as rightly said by many of our seniors, that preventive approach is definitely good, but when we detect the things in early stages, if we do the proper treatment by any step up or step down approach, and with the like what you have said, that the right approach for the right type of wound, that is more important rather than delaying the healing, and because this will increase definitely the patient suffering, and it will cost to the company also, and it may lead to some salvaging of the limbs and functional disabilities also. So this during this pandemic, sir, we are finding opportunities to connect with people like you who can give us some insight on different aspects of preventive, promotive, and curative aspects of many different diseases and other medical subjects. So thank you very much, Dr. Sunil Choudhary, sir.
Rehabilitative also, Dr. Sandeep.
Yeah,
Rehabilitative.
Rehabilitative is also very important.
Yes,
and
absolutely. It's such a vast topic, Dr. Sandeep, that it's difficult to cover all the aspects, but it's very encouraging that all your panelists had such intelligent and very great questions, because I think I tried to cover a small part of the whole thing, but answering all these questions, we have spoken about a variety of subjects that we didn't touch, and I'm so glad that we were able to do that as well. It's an honor and a pleasure, sir.
Yeah, we would love to have many more sessions with you on different aspects which you have touched. And because there are a lot of connections with you also, our like president, vice president, they are also from Maulana Azad Medical College.
Oh, fantastic. Maulanians.
Rajiv Kumar Jain, Dr. Shashi Bhushan, our joint secretary, is also from Maulana Azad. Our treasurer is also from Maulana Azad Medical College. So
I'm so honored.
So we'll keep in touch with you, sir. And during this COVID times, we have designed a small certificate to you. That is a virtual.
Thank you very much.
Felicitation for you, sir, and we'll send it to you through email.
Thank you very much. I will definitely frame it. I'll frame it myself.
Yeah, sure, sir. We'll have many more interactions, and in February we are having our annual conference also. We will do it on a hybrid mode. So we'll request you to have a session during that.
I'd love to have it.
Yeah, and we will have much more interactions, much more
Yes.
connections with you, sir. So thank you very much, and thank you all the panelists for sparing time, and especially Dr. Choudhary to spare valuable to us from his busy schedule. So thank you, sir. Thank you.
It was extremely, useful for me as well, because sometimes unless you talk to the people who are providing the first point of care, you don't know exactly what issues they're facing. But it was very heartening to see that all of you are so educated in the way you were actually asking questions. And I'm sure whatever we have discussed will go a long way in helping our patients as well. Thank you very much. It was a great opportunity. Thank you.
Thank you.
Okay, thank you.
Thank you all. Thank you so much.
Thanks. Thank you.